Welcome back to this edition of UroChat. In studio we have Dr. Alvi. Thank you for being here.
Thanks, Steve.
We've had several great conversations so far about HIFU and its treatment for prostate cancer. We then talked about erectile dysfunction and several treatment modalities for that issue. Now we talk about urinary incontinence, something that I personally have dealt with extensively as probably a result of the radiation that I had from my prostate cancer. And so extremely debilitating issue, really brought me to my knees literally, and really devastated the quality of my life. So I'm grateful for you being here and sharing with us some information about, I guess, first of all, what is urinary incontinence, and then we'll talk about some of the treatment options.
Yeah, so urinary incontinence are different types. One is called stress urinary incontinence and one is called urge urinary incontinence. So stress incontinence is most commonly seen after radical prostatectomy or radiation. When you cough or sneeze or do any heavy weight lifting, you will have leakage of urine. And I would like to talk in context with prostate cancer, especially when patients have radical prostatectomy. There's an initial recovery phase. It can take 6 months to 12 months to get continent, but some of the patients can have permanent damage to their sphincter, which controls the urine. So requiring anywhere from 6 to 8 pads after the surgery, and slowly it keeps getting better with Kegel exercises. But after a year or so, if patients continue to have incontinence where they're requiring more than 1 pad a day, is considered significant. And then there are treatment options for that.
And I know personally, after surgery, I did really well with urinary retention or urine retention. But for me, it was 9 months after radiation. And is that fairly typical or atypical that some men really have a hard time with incontinence after radiation, especially?
So let's say if a patient has aggressive cancer, they have radical prostatectomy and they will need radiation afterwards. So typically we try to delay the radiation for 3 to 6 months sometimes until they're continent, right, or relatively continent, at least they're down to 2 or 1 pad. Because if you do radiation right away, it can really lead to some major permanent damage to the sphincter, and the recovery can be very bothersome. So it's very important to plan it accordingly, that if patients will need radiation, delay it until patient is dry. I have patients, sometimes we wait up to 12 months to or longer, that they can be dry or incontinent before they can consider radiation, because radiation will make their continence worse.
So what are some of the treatment options for urinary incontinence? I know we've got slings, we've got artificial sphincters, there's even clamps, there's a whole variety of treatment options. Can you walk us through some of those, doctor?
Yeah, so I think first important part is to you have to quantify how much leakage they have, how much incontinence they have. So sometimes we can ask the patients, they can weigh their pads, and that's one way to quantify it, or the number of the pads. We do some investigation beforehand, urodynamics testing. If patients if they're diabetic, sometimes they can have urge incontinence, where they have an urge to urinate, they can make it to the bathroom. That can be treated with medications. So very, very important to differentiate between urge and stress incontinence. So urodynamics testing can help us to identify that. And then we take a look in the bladder, the camera, cystoscopy, make sure there's no scar tissue. If we are planning to do any treatment for that, to make sure there's no scar tissue, that is also very important.
I still have nightmares. The
Cystoscopy.
Cystoscopy is just awful. It is what it is, but I know it's necessary, but it's pretty intimidating.
Yeah, it's for men, going through urethra and while they're awake is not fun, but definitely get us a lot of information, which is very beneficial for the patient. So the initial treatment is, penile clamps is non-invasive, non-surgical option where you can buy a clamp, but it's not fun for a younger guy or patients who are younger to use. Typically we use penile clamps for the patients who are not good surgical candidates. But there are treatment options which are very excellent. So typically the idea is patients who have about up to 1 to 4 pads kind of incontinence every day, we have male suburethral sling. So it's basically polypropylene material which is made in the form of a hammock or sling. We make an incision in the perineal area, and then we identify the urethra close to the sphincter area, and then we place the sling under the urethra, which will act as a hammock under the urethra and will prevent incontinence. So that is very effective for incontinence which is less than 4 pads a day. So the nice thing about sling is that you do not have to deal with any gadgets. It's just a one-time procedure, it's done, and is very effective.
Sure. You initially mentioned the clamp. Intuitively, I would think that one of the challenges of the clamp would be that is there a higher risk of infection, because should the bladder, should it not be stained, or the urine stained inside the bladder? But if we have a clamp, then the urine's going to be leaking down closer into the penis, and would that possibly create more infections?
Yeah, I think it's good to teach the patients that they should try to empty their bladder every 4 hours. Bladder has capacity to hold urine up to 4 to 6 hours. If patient waits longer, retention can lead to urinary tract infections. But I think it's important to teach the patients that they should, we call it timed voiding, that they should try to empty their bladder every 4 to 6 hours and don't wait too long. This way you can avoid that.
Okay, but having the clamp necessarily doesn't increase the risk of infection?
There's a lot of data on that having a penile clamp will increase your risk for infection. Hypothetically, you can say that, but we don't have a lot of data on that.
Okay. So moving from the clamp, then we talked about you have the mesh sling.
Yes.
Some of the pros and cons of the sling.
Yeah, so if you have, it's very important to quantify your incontinence. So if you have, really 8 pads incontinence and you place a sling, you're not going to see the same results because you cannot make it that tight.
Yeah, I was wearing more than 8 pads and 4 to 5 diapers a day, so the sling wasn't even an option.
Yeah, it wouldn't be a good option for you, exactly. So that's one of the most important things, is to make sure the patients how much incontinence they have. Advantage is it's a one-time procedure. You don't have to use any pump or any reservoir or anything to deal with. Disadvantage, there's risk of infection, a little bit of pain. The risk of mesh erosion with the sling is not that high; it's very low. So this short term, I would say. The long term is that slings after a period of time can become loose and incontinence can come back.
When I hear the word mesh, I immediately think of hernia mesh, and then we've seen TV commercials recently, mesh, having some complications. Is this a different type of mesh, and is it located in a different part than normally, like for an inguinal hernia would be? So are we talking totally different things here?
Yes, I think mesh is kind of it has different usage in hernia surgery for female. We do a lot of vaginal slings for females as well, and every organ has a different complication rate and risk. I think for urethra, with the simple sling, the risk of erosion is quite low, so we don't see that many complications. But it's hernia, it depends on the area, how sensitive the skin is. The risk of mesh erosion is different in different areas.
Okay, that's great. So, and then when we have a person like myself where the sling is just not an option, what is the next level that we have in the toolbox?
Yes, so the next thing would be artificial urinary sphincter. So the idea is that it's a device where basically there's it's a cuff which goes around the urethra. It has liquid in it. So it also has a reservoir or pressure regulating balloon, and and basically what you do is it stays closed all the time. And it's a procedure as well. We have to implant the whole device, and then the cuff remains closed all the time. So whenever you want to urinate, you press this pump button in your scrotum on the side. You typically place that on the side of the testicle. So you squeeze that, the cuff opens up, which means the fluid from the cuff goes back into the reservoir, and then you can urinate you have 90 seconds to urinate, and then automatically it closes up again. So that is the most effective treatment option for stress urinary incontinence. So any patient who have 3 pads or more, 3 to 4 pads or more incontinence requiring pads, their incontinence can go significantly down.
Absolutely. Full disclosure, I have the artificial urinary sphincter. It has completely changed my life. I've had it now for over 2 years, and just like you said, doctor, I squeeze the pump, it activates, I can urinate. It's open for about 90 seconds, like you said, from what I can tell. Usually even when I hydrate a lot, I don't urinate for more than 40-45 seconds. Sure. I'm done. I go about my way. I'm dry like I was when I was 15 or 18, and then there's no side effects. One of the things that a lot of people ask me is, and I want to ask you, can people see it? Can the patients feel it? Are there any, when you think about an implant, you think of a disfigurement. Anything like that whatsoever? So,
typically not a typical complaint, because it's a very small, elliptical tube which sits on the side of your testicle. So your anatomy doesn't change much. It's sitting in the perineum around the urethra, so you can't really feel that or see that. So physically, if you're standing naked, it will be very difficult for somebody to see that you have a sphincter placed. But as a patient, we don't have many patients complaining that when they sit down, they feel the sphincter or the pump. But you might be able to, your personal experience. But with the sphincters, when I place, I don't have any patient complaining that they feel the cuff or anything like that.
Yeah, right now sitting here, I feel nothing whatsoever. My back hurts a little bit. And maybe my feet hurt a little bit, but I've never once could feel the actual implant itself. It's just remarkable.
Yeah, no, that's great. I'm glad you're doing great. But it's a great treatment option. The cons are, I would say, risk of infection is there, and risk of mesh erosion is there. So the cuff erosion, I would say, if you had radiation, your urethra is more sensitive, so there's a little higher risk. So you just have to be very careful when you place the cuff to make sure it's not too tight. So we want to make it tight, we want to make you dry, but you have to control your feelings that if you put it too tight in a urethra which had radiation done, you can have complications in the future. So I think that's a very important technical point. The risk of infection is quite low as well. And there are sometimes lifespan anywhere from sometimes 5 to 10 years, I would say. After that, sometimes you have to replace it, so it can be replaced with a new equipment. Like penile implant, it also has risk of infection. And if it doesn't get infected, you have to take the whole thing out and place a new one in.
Sure. And when you do a revision or a replacement for a patient, at that point, would you then put the cuff in a different part of the urethra, so then to give that one part a break and to start to then work on the other part of the urethra?
That's generally advisable, yes. So if you take it out and if you have enough space and the urethra is not too scarred down, if you can find a different place for the placement of the cuff, it would be much better. Less risk of erosion.
Oh, that's fantastic. So when you look at all the treatment options, it seems like this is something that escalates just like the treatment options for erectile dysfunction as well, possibly? Meaning, are there times where you need to do the sling or you try the sling and it may work for a while, but the man may gain weight or may become more incontinent, then you move into the sphincter? Does that ever happen, or is it just you pick one option, that's all you have?
Well, I think, yeah, so, you can do that. So if a patient had a sling, it's not very common, but if a patient usually have incontinence 3 pads, it usually doesn't get that worse.
Okay.
And once you put the sling, they're down to maybe 1 pad or none. With the sphincter, we can see that, if the cuff stops working, or there is a malfunctioning, that you will see the patient is starting leaking again, or they're requiring more pads, then you have to go back and replace the cuff or replace the whole thing. But typically, if you have a sphincter, you're going to need a sphincter. If you had a sling, most likely you're going to go upgrade to sphincter. So if your leakage comes back or it gets worse or it does not get better, the next step would be artificial urinary sphincter.
That's fantastic. Well, as I mentioned, doctor, the artificial sphincter has changed my life, and I'm grateful for you being here tonight and sharing with us a lot of your expertise.
No, that's great, Steve. I'm glad it's working for you, and hopefully, we'll continue to do it for other patients as well.
Absolutely. And speaking of that, where can patients contact you if they want to learn more about urinary incontinence and the treatment options you provide?
Yeah, so patients can visit me on my website, azurologicsurgeons.com, or they can contact my office, and we are happy to provide them more information either on website, or they can come and see us, and happy to give them more information about incontinence.
Thank you, Dr. Alvi, for being here. This concludes this segment of UroChat. We had the honor of having Dr. Alvi with us tonight, a pioneer and expert in HIFU for treatment of prostate cancer, as well as an expert in the prosthetic world of erectile dysfunction and urinary incontinence. So thank you all for being here, and thank you, Dr. Alvi.
Thank you, Steve. Take care.
Appreciate it. All right.